Hello, hello, hello. Hi, everyone. Happy Friday again. I see we have some people that are already logged in. That's great. I'm going to give just a few more minutes to let everyone get settled, to let some of the others join the room before we start. How is everyone? I hope you guys had a really good week. I cannot believe that we are almost mid-November right now. This year has flown by. I'm still like scratching my head wondering where the year went. However, I'm really happy to have you guys here. This is the third part of a 3-part webinar series that I've put together to discuss the different hormonal changes that a woman goes through throughout her reproductive life. Today we are on the third part, and we're going to be talking all about menopause and how we can navigate into that transition without it being so painful. There's so many things that are happening within the body during this time for a woman, and oftentimes she doesn't get the support that she needs, whether that's medical support, emotional support, social support from her community. So I'm really excited to share this with you guys. I treat a lot of menopausal women and postmenopausal women, so this is something that's really near and dear to my heart. Before we start, I just wanted to do a quick reminder that I do offer a free 10-minute meet and greet for any prospective patients. This is an opportunity for you to express any of your health concerns, and then for me to give you my treatment approach and for us to see if we're a good fit for each other as far as moving forward within a doctor-patient relationship. So you are able to schedule that free meet and greet online, www.livingwellnessmedicalcenter.com, or you can call the front desk at 480-588-6856. All right. So yeah, we have some more people that are logging in. So I'm going to go ahead and get started. Hi, everyone. I see people are saying hello. If you have questions, please put them in the chat box. We will make time to answer them. No question is a dumb question. I welcome them all, okay? So let's get started here. All right, here are some terms before we even start. So we have perimenopause, we have menopause, temporary menopause, induced menopause, and then postmenopause. So this pictograph here is showing us what those different stages look like. So a perimenopausal woman is someone that's right before that menopausal phase. And how do we classify menopause? We classify menopause medically for a woman that's gone 12 months without a period. So no cycle, 12 months. That's how we clinically diagnose menopause. We also have different levels that we look for as far as blood chemistry that can confirm those changes. But as far as the timeline, it's a whole year without any periods. Once you hit that 12-month mark, we consider that menopause. So perimenopause is right before that 12 months. Women definitely experience symptoms within that phase. And this is a nice sweet spot for a doctor like me to start initiating treatment because I'm already knowing what's coming, right? So there's a lot that we can do to help transition the woman into menopause so that those symptoms are not as severe. The average age of menopause is 51 years old. However, that can be plus or minus 5 years. I typically see women coming in around 49, 50 years old with some complaints and symptoms. 51 is the average. Temporary menopause. Temporary menopause is usually menopause that's induced through medication, mostly for our cancer patients. So chemotherapy or radiation. This is when menopause or a period stop for a year from some medication, and then they resume after that medication has ended. Induced menopause. Induced menopause is different from temporary menopause because induced menopause is specific to having the ovaries removed. So this is a surgical removal of the ovaries, which means that we don't get that estrogen anymore. So that puts us immediately into menopause. You can't revert back from that. Whereas with temporary menopause, the cycles usually tend to come back after that treatment that stopped the cycles has ended. And then postmenopause is that period right after you hit that 12-month mark. So similar to the perimenopause, Like right when you're in that window, you're not 12 months yet, but let's say you're 8 months, 9 months, that's considered perimenopause. Postmenopause is like the day after that 12-month, you're considered a postmenopausal woman. Okay, so it's a very short little window that menopause happens and then postmenopause. And you can kind of see that here with the pictograph. All right. Factors. So here are some things that can contribute to the severity of menopause and the symptoms that a woman may experience. Like we mentioned before, radiation, chemotherapy. There are some other drugs that can cause menopause to either come earlier or later. Familial and genetic factors play a role. BMI, so your body mass index, what does your weight look like in comparison to your height? Smoking and toxicant exposures. So you guys will see that there's a theme between all of these webinars that we've had over the past several weeks, all the way from starting your period to maintaining a period, into fertility and into menopause. There are similar things that affect how your body will respond to those hormonal fluctuations. And you'll see that often. A lot of the same systems are in play. There are just different things that are happening within that system. All right, physiologic changes. So what is actually happening to the hormones in menopause? So one, we are losing our follicles. Remember, the follicles are what matures the eggs in the ovaries. This is what's maturing the egg before it is ovulated and then moved from the fallopian tubes to the uterus, where it then waits for fertilization and implantation. So we lose those follicles. A drop in the hormones, so in progesterone, testosterone, and then most importantly, estrogen. Those hormones start to really drop. And then an increase in FH and LSH. I don't know if you guys remember that from the previous two webinars, but FSH and LSH are those hormones that are released from the anterior pituitary that signals the ovaries, the testes, the thyroid to do a certain function. So whenever someone has issues with their cycles, we look at FSH and LH. I made a typo there. And whenever someone's going through menopause, we also look at the same thing. So these two hormones in particular give us a lot of information around the reproductive system in a woman especially. In this graph here, you can see estrogen is the purple line and progesterone is this dotted orange line. So when we're in our fertile years, we see how estrogen and progesterone are increasing, and they're supposed to be nice and high to encourage fertility. And then as you see, once we get into menopause, estrogen stays pretty steady, but progesterone starts to decline pretty rapidly. Progesterone is one of those hormones that is most commonly really low in women, even in women who are not in that perimenopausal age. We have young girls. I see really young girls, 16, 18 years old, whose progesterones are really low. Stress affects this. Environmental toxins affects this. Diet also affects this. So we see here in perimenopause, this drastically drops. Estrogen is still trying to stay steady, but as we get into the menopause, everything's like crazy. Estrogen is up and down, up and down, up and down, and progesterone is almost at its lowest point. So this up and down that's happening with estrogen is what causes the bulk of the symptoms that women experience with menopause: the vaginal dryness, decrease in libido, hot flashes, night sweats, changes in mood. A lot of those can be tied back to these hormonal imbalances that are happening. Okay, so HPA Axis. Again, LH and FSH. I really like to show this picture whenever I'm talking about hormones because it does such a good job of showing you guys that three-step process of what's happening with the hormones. Everything starts in the hypothalamus, which is in the brain. That's our grand central, the master station. And then our pituitary is our grand central station. So this is like where all the hormones are lining up, waiting for their destination. LH and FSH are then released from the pituitary, and then they go to their final destination, which is usually testes or ovaries in this conversation, okay? Testes makes testosterone, ovaries makes estrogen and progesterone. As women, we do make testosterone. We don't make as much as men. But we do make it, and it does have a really important role in our hormones. So whenever we're going through menopause here, what happens is the ovaries start to decline. We start releasing less estrogen and less progesterone. And then that sends a signal back up to the hypothalamus, the brain, that says, hey, we're not making hormones anymore. And so then the brain tells the pituitary, make more hormone. And this is why we test the LH and FSH with menopause, because usually those numbers are higher. And let me show you guys. Let me do a pointer here so that you can see what I'm talking about. So here, estrogen and progesterone. Once this is really low, this signal up here goes to the brain. It says, hey, make more hormones. This goes to the pituitary, which says make more of these. These guys are usually elevated in menopause because these are low, okay? So that's how that process works, and that's why we check those hormones. Oops. So this is no fun. I'm going to have to literally delete all of the scribbles that I just did. Bear with me. Here we go. All right, next slide. Adrenals. All right, adrenals are so huge. Adrenals are so important for our overall health. But whenever I'm treating a woman that's going through these hormonal imbalances right before menopause, I always treat the adrenals. And this is why. The adrenals are very important for a lot of our sex hormones. On the left, you can see what they look like. I like to call them the party hats of the kidneys because they're these two little glands that sit right on top of the kidneys, and they look like little party hats. So that's what the adrenals look like. And if you look on the right and you see this flow chart here, you see testosterone, progesterone, and different types of estrogen, estrone, estradiol, and estriol. All of these are made in the adrenals. Obviously, we also make these sex hormones in our ovaries, but the reason I like to treat the adrenals is that we already know that the ovaries are going to decline. That's a part of our natural design. As we get older, we just don't make as much of estrogen as we're supposed to because we're not reproducing, we're not having children. However, the adrenals still make some of these hormones. So if I can support the adrenal, I can still provide some backup support for when those hormones decrease in the ovary. So it's almost like you get a backup supply. This is also important because we live in a very stressful world, especially on the Western part of the world. We live in this grind mentality. We're always working. As mothers and as women, we take care of everyone else but ourselves. And what happens with that is that we end up producing more cortisol. Cortisol is our stress hormone. If you see here, we start at the very top with cholesterol, and then we go into pregnenolone, and then pregnenolone can either go down to progesterone, or it can go to the right, and then go into cortisol. Whenever we're having high stressors, instead of our body doing pregnenolone and progesterone, we shunt that to make more cortisol. Okay, so let me show you this too with the whiteboard. This is important. So the normal flow is to do this, and then all of these other things happen. When we're stressed, we do this, then we do this, then we do this, then we do this, then we do this. We end up making more cortisol because our body is always trying to keep us safe. So in our mind, it isn't differentiating our stressors, okay? It just knows that we're under stress, whether we're in traffic, we're upset about money or something with our job, we're arguing with our partners or family issues, the state of the world, what have you. Whenever we're stressed, we're going to make more cortisol because our body's trying to get us out of that situation. And when that happens, we don't make the progesterone, which is really important for mood, especially in women. And we don't end up making these guys, which makes testosterone, and then it makes our estrogen. So this is why treating the adrenals is so important before menopause happens, so that it gives you that overall support to maintain some of your hormones. Okay. I love showing this graph because it really is like the mastermind to understanding endocrinology. All right, let's go to the next one. A comprehensive workup. So I have this graph here to show you just how interconnected the endocrine system is. You see all of these different connections. This is why I do full comprehensive labs on a woman who's going through menopause or any other condition. I don't just want to see her sex hormones. I want to see what her insulin receptors look like. What does the blood sugar look like? What does her lipids look like? What's vitamin D? Cortisol, obviously. CBC, so white blood cells, red blood cells. How is kidney doing? All of these things are important because our body is one system. Okay, we're not separate from our parts. We're a sum of our parts, and they all work really well together. So sometimes symptoms that a patient may have, yes, it could be from the hormonal imbalances, but there could also be other things that are happening. So the comprehensive workup helps to give me a complete idea, like where are her weak spots? Where are the areas that I can better support this person's body as it goes through this already hard transition? So again, this is just showing the importance of treating the whole person instead of just treating the symptoms. All right, declining estrogen. So in menopause, all hormones decline. Testosterone declines, progesterone declines, estrogen declines. However, the main theme of menopause is estrogen. What does estrogen do in the body? Estrogen is really important for our brain health. It's really important for our bones, for our breasts, for our muscles, the way that we store fat. All of those things are influenced by estrogen. Estrogen is that hormone that keeps our vessels and our skin nice and elastic and plumpy. We get that bounce back when we're really young as far as our skin and the way that we can bounce back from injuries or inflammation. Like estrogen helps with all of that. So when estrogen starts to decline, that's when we start to see symptoms that are really common in menopause, and we'll talk about that. So think about estrogen as like your nice, plumpy, useful hormone. So here are some common symptoms for menopause, and these are some of the ones that we're going to talk about with the webinar. Hot flashes, hot flashes, decreased libido, issues with sleeping, night sweats, irregular cycles, headaches, vaginal changes, you name it. There's a lot that can happen within this process. Most of it is coming from the decline in estrogen. The estrogen really drops, guys. It's something like 75 to 80% of our natural estrogens drop when we go into menopause. That's significant. And depending on what that person's adrenal health looks like and other processes in the body, it can really dictate how severe a woman's symptoms are when she goes through this transition. 70% of women experience night sweats. 80% of them will experience hot flashes. I see that a lot. So first things first, changes in the menstrual cycle. So as a woman is starting to approach menopause, some different things can show up as far as what her periods look like. Periods can get longer, meaning that instead of your period being every 28 days, maybe it's every 35 days or every 40 days. So you're having more infrequent periods. Periods can also come more frequently. So having a period every 2 weeks, having a period every 15 days, the flow also can change. It can get heavier, it can get lighter, and some women just have spotting. So it can be all over the place. The main thing is being able to identify that there isn't anything regular about my cycles right now. That's typically the first sign that we're entering into that perimenopausal phase. So this can look different for every woman. It's not always the same. Some people, they have their period normally, and then one day it just stops, and then they don't have it for a whole year. I've had some women who go 8 months without a period, and then all of a sudden they're bleeding again. So this is why tracking periods, again, is really helpful in helping your doctor differentiate what's happening. The reason why we have these changes in the cycle is one, because we don't have those follicles anymore. If we don't have those follicles, we can't ovulate. If we can't ovulate, we can't make progesterone. All of those hormones are important for stimulating and maintaining lining, which then helps us to release it, which is a period. So if we're not having those initial things happening, we don't have a period anymore. And that's what happens when our estrogen starts to decline. Hot flashes and night sweats. I really like talking about this because of how many women experience this, okay? In the medical world, we call this vasomotor symptoms. Some triggers for hot flashes and night sweats: spicy foods, warm drinks like coffee or tea, a warm environment. So living in the desert can trigger. Usually women have more severe hot flashes and night sweats during the summer just because the environment is hotter. Alcohol is a trigger, and caffeine is a trigger. We don't really know exactly why hot flashes and night sweats happen. We know that there's a tie with estrogen starting to decline and testosterone and progesterone. But other than that, we haven't really identified that full picture of what triggers hot flashes and night sweats. What's interesting about this is that different women in certain regional areas of the world have different experiences. So in Japan, hot flashes and night sweats are very, very, it's a low occurrence. They don't have it as much as we do here in the United States. And there are even some women in Mexico who don't have any hot flashes. So that makes me think that there's something in our environment, in our way of life, that is also contributing to these hot flashes and night sweats. I thought that was really interesting. Some things that you can do for hot flashes and night sweats: I always encourage my women to carry around a little spray bottle of water and peppermint oil. This is a temporary fix, so it won't get rid of all of your hot flashes and night sweats. But that peppermint is a very cooling oil. So what happens is you get that nice, tingly, refreshing feeling that can cool you off in the moment. So that's one thing that you could do. We also treat hot flashes and night sweats with herbs. Black cohosh is a really popular herb. Vitex is another one that helps. Hormone replacement therapy can be really helpful, and then homeopathy can be helpful as well. So consulting with your doctor about these different options, or your naturopath, she'll be able to help you figure out which one of those methods are best for you. I do want to say one more thing on the changes in the menstrual cycles. So some women do have heavier periods, which we mentioned before, but if you are soaking through 16 pads within a cycle, or you're bleeding more than 7 days, that is your cue to talk to your doctor, because hormones can be changing, yes, but there could also be other underlying factors that's causing this bleeding to happen, like uterine polyps or uterine fibroids. And depending on how much blood you're losing and how often you're losing, it can be causing other imbalances in the body, like iron deficiency, anemia, which can cause dizziness, lightheadedness, shortness of breath, fatigue, which is really huge, cold intolerance, so feeling cold all the time. These can tie back to those underlying factors that's causing the bleeding to be heavier. So just make a note of that, so that if you do experience it, you can talk to someone who can help work up what's happening. Vaginal changes. So vaginal changes, I see this a lot. On the left side, you see where it says healthy vagina. You see how that lining is nice and thick? You have the blood vessels there. The vaginal walls are elastic, meaning they can stretch and then go back to that normal shape or tone. You're able to lubricate, so you don't have any dryness. Lubrication is present before sex. This is what a normal, healthy vaginal tissue should look like. As our estrogen decreases, remember that's our plumpy hormone, we start to lose the elasticity of our vaginal tissue. We get vaginal dryness, which is usually the first symptom that shows up. And then the itchiness comes in. The pain with sex comes in. Spotting comes in whenever a woman wipes, or if her underwear rubs the vaginal tissue. Some women have spotting. This is because the estrogen isn't there anymore to help maintain the integrity of those vessels and that tissue. So some things that we can do for this, we have different lubricants that can really help. Estriol, which is a type of estrogen, is our most weak estrogen. We use suppositories with those. So suppositories with the estrogen and some vitamin E, some cocoa butter over time that can really help to nourish that tissue. So I love to use that in practice. Another thing, bioidentical hormones, so actually giving the woman estrogen. We'll talk about other ways that she can get that other than vaginal estrogen. Testosterone can help with this because testosterone eventually converts into estrogen, so that can be really helpful. Something else that we see on top of the vaginal changes is that some women start to have more urinary tract infections or bladder infections or incontinence. Incontinence is when you can't hold your urine. So if you pee or if you giggle or if you sneeze or you giggle or you cough and you tinkle a little bit, that's because those muscles aren't able to hold on to the tone anymore. And whenever that happens in the vaginal tissue, it's also happening in the tissue around the vagina. So the bladder can be affected, the urethra can be affected. So again, we want to make sure that we are supporting that tissue to prevent the UTIs, to prevent the pain with sex, to prevent the bladder infections. Yeah. This is very easy to fix or to treat. A decreased libido. So I have a lot to say about this. Libido isn't just a physical thing. It's an emotional thing. It's a psychological thing. It can be a medical thing, and it can be a hormonal thing. There are so many factors that tie into the desire for sex and being able to enjoy sex. So the hormonal piece, we're losing estrogen, we're losing testosterone. If your vaginal tissue doesn't feel good, if it's thin, if it's dry, if it's starting to tear easily, sex is not going to feel good. It's going to be painful. And I've seen this a lot in practice. It isn't that the woman doesn't want to have sex, but when she does have sex, it hurts. So then before the sex is even happening, she's anticipating for it to be painful, which indirectly decreases her desire to have that intercourse. So that's important to take into consideration. Social support. So the lack of social support from a woman's environment or the emotional support from her partners or the people around her, as far as understanding what's happening with the hormones, that can definitely kill your libido if you don't feel that you're being heard or you're being seen or listened to. Medications can decrease libido. So antihistamines, Claritin, Zyrtec, Benadryl. If you're taking those for your allergies long term, this can affect your libido and your desire. Antihypertensive. So medications to lower blood pressure can decrease libido. Antidepressants can decrease libido. And oral contraceptives, so birth control, can decrease libido. I see a ton of women who are on either 1, 2, or 3 of these medications. And sometimes once we get those symptoms stable, the reason why they're taking those medications, we start to see that libido comes back. How do we treat decreased libido? So number one, identifying where the lack of desire is coming from. Is it because it's painful? Is the relationship with her partner or partners, are those relationships deteriorating? Are they poor relationships? Does she feel supported in those relationships? What are the hormones doing? What's in her environment? What does stress look like? And are there any other medical imbalances or conditions that could be causing this to happen? So once we identify that, we then know how to treat it. If it's a hormonal thing, again, hormone replacement therapy can be really helpful, particularly testosterone. Herbs, maca is a really popular herb in treating this particular symptom because maca helps us to hold on to our testosterone. And then doing some emotional counseling can be really helpful, especially if there's a disconnect between the woman and her partner, which I always like to encourage, especially during a stressful time as menopause. All right, energy, cognition, mood, and sleep. So I see this a lot. If a woman isn't having hot flashes, night sweats, vaginal tissues, okay, she almost always has one of these symptoms. So either sleep is interrupted, mood is starting to be very changeable. So weepiness, feeling sad, more anxiety, depression, cognition. So difficulty remembering names, places, dates, having a hard time staying focused and being motivated. And then the energy, just being really fatigued and not feeling like they have enough support to do what they need to do in their day. So how do we treat this? Again, what's happening? What do the hormones look like? Estrogen is super important for the brain. It helps to stimulate other neurotransmitters like dopamine, acetylcholine, and serotonin. These are all very important for cognitive function and for mood. We see a drop in these neurotransmitters after childbirth, during menopause, and especially with induced menopause. So if you have a surgery where your ovaries are removed, that decrease, that immediate decrease, causes a really severe presentation of what these symptoms can look like. The induced menopause can be so heavy and so severe because in regular menopause, you're usually inching your way into that transition. With induced menopause, it's literally overnight. Once those ovaries are removed, you're immediately into menopause. And your body's like, I just had estrogen a few hours ago. Now I don't. And it freaks out. And that's when we see a huge decline in the emotions. I also thought it was kind of cool that that happens after childbirth. We all know how huge that is for a woman to give birth. So many things changes after that time. And that's happening also in menopause. So again, similar themes within the reproductive system. What else do I want to say about that? As far as brain support, what are some things that we can do to keep our brain healthy? Healthy fats are really important. Think about a Mediterranean diet, olive oil or eating olives, flaxseed oils, avocado, wild caught fish is really great. Antioxidants are super important. So berries, eat as many berries as you can. Berries are full of antioxidants and they're a low glycemic food, meaning they won't spike your blood sugar. So that can be super protective against any free radicals or cellular damage that happens in the brain, especially as we lose estrogen. And also things like vitamin C or glutathione, which are other antioxidants as well that can help. We also use herbs. Ginkgo is a really popular herb that we use. Those herbs are called nootropic herbs because they help to stimulate circulation in the brain and to keep getting that blood supply so that the brain can fire and communicate with different cells in the nervous system. As far as the mood, how do we treat that? So one, talking to the patient about what their experience has been like, their social experience. How do they feel in the world as they go through these phases? So having those conversations, understanding where they're coming from and giving the person a space to actually express how they feel and to be heard can be really helpful. Progesterone is super helpful for mood and for sleep. Like we saw in those earlier slides, progesterone declines and it declines quickly. And it's really helpful for our cognitive function, our mood, and our sleep. So if we give a woman that back, we typically see that mood improves and sleep definitely will improve. Other herbs that we can use for sleep, so popular sedative herbs, kava, valerian, passiflora, lavender, and hypericum. Those are herbs that can help to tonify the nervous system and help with sleep. Those are some that I use in practice really commonly. And then making sure that we're addressing stress. So if someone is really stressed, it zaps your energy because you're making more cortisol. So again, treating the adrenals, making sure the patient has different coping mechanisms and tools to address their stressors. Joint pain. Why are we having joint pain with menopause? Again, estrogen. Estrogen is super protective for the bone. Once estrogen starts to decline, we don't have those protective mechanisms anymore. This is why when women go into menopause, they're already at a higher risk for osteoporosis because we don't have that protection from estrogen anymore. What are some things that we can do to help with the joint pain? So one, doing a DEXA. DEXA is a bone density scan. It's a type of imaging that helps us to look at different bones in the body, see how strong those bones are. That gives me an idea of, is this person already approaching bone deterioration? Are they holding on to their bone? Do we need to rebuild bone? What does that look like? The DEXA gives us that information. Typically, we don't start DEXA until after a woman has went into menopause. Some of the standard guidelines are saying 65 or older. However, I like to treat all of my women for a DEXA, especially if they're in that perimenopausal phase. Because again, if I can tell that they are already starting to lose bone before their periods have stopped, I want to treat it then. I don't want to wait until they're in osteoporosis or osteopenia and now they're at a higher risk for fractures to try to rebuild bone. Let's keep the bone that you have and keep building it instead of trying to make up for things that we've lost over time. Other things that are really good for the bone is stress, good stress though. So we have bad stress and we have good stress. A good stress for the bone is weight-bearing exercises. So any type of exercise where you're using your body weight can be very helpful. That stress on the bone helps to push calcium back in the bone and strengthen it. Another easy thing I tell my patients to do is take a walk, but take a walk with a backpack and put some books in your backpack so that you get a little bit of extra weight. Maybe doing some stairs with the backpack. Again, that stress, that weight-bearing exercise helps to push the calcium, the vitamin D into the bone so that you hold on to it more. Diet is also super important when we're talking about bones. We need to be in an alkaline state to maintain our bone. We don't need to be in an acidic environment. What causes an acidic environment? Soda, coffee, refined sugars, processed foods, high fats, animal fats in particular, alcohol, dairy. Those are really inflammatory foods that cause the body's pH to be more acidic, and that can start to leach your bones. Your bones will start to weaken because you're releasing the minerals from the bone to try to alkaline that pH in the blood. So if we can decrease how much acid we're getting from our external factors, we also help to maintain our bone. Vitamin D, vitamin K2 is really helpful. Zinc is helpful. Calcium is helpful. And estrogen. So again, hormone replacement therapy can be protective for this. Make sure you talk to your doctor about supplementing calcium. We don't want to get too much calcium. We also don't want to get too much vitamin D. There are consequences if those are elevated. So it's important that you talk to your provider about what are healthy levels to look for. And as far as supplementing, how much should you take every day? It's going to be different for each person depending on what your labs say. Weight changes, another unpleasant symptom that usually comes along with menopause. So typically this has to do with decreasing testosterone because testosterone helps us to maintain muscle mass. When we have more muscle mass, muscle burns more calories at rest versus fat. So when we lose that mass, we're not burning as many calories just at rest. Also, the thyroid and the adrenal can really affect this. So if the body is in high stress, which it typically is during this process because hormones have dropped, the patient doesn't feel well, cortisol has raised, your adrenals are working harder. Adrenals and thyroid are like sisters. You can't touch one without touching the other. So eventually, thyroid starts to work a little bit harder and we see hypothyroidism. Thyroid is like the engine of our body. It really sets the tone for our metabolism. So again, this is why that full workup is important because we're looking at all the factors. We're not just looking at the hormones. We're seeing what else is off that can be causing this metabolism to happen. Also, most women don't want to work out as much during this phase because they're tired and they don't feel good. So that's another thing that can happen. We're not exercising, we're not moving as much, we don't burn those calories away that we did when we were younger. I'm also looking at other familiar factors. So does this person have a family history of diabetes or elevated cholesterol? And figuring out what that piece looks like as well. All right. So to sum up everything in treatment, obviously, it really depends on what your symptoms are. Each treatment is going to look really, really different. As naturopaths, we have that freedom to use all of our tools to get really creative and make an individualized treatment plan for each patient. But to sum it up, we do supplementation, so giving you vitamins and minerals that you're lacking during this time. Herbs, again, so dear to my heart. Herbs are beautiful. They work very well in the body and they're gentle. Diet, making sure that we are supporting you from that way too. If I can support a person through diet versus using supplements, I'm going to want to do that because that's a natural source of those micronutrients. Movement, so making sure that the person is staying active. Exercise, walking, weight training, yoga, Pilates, any type of movement that feels good for you. That's important because it's going to continue to keep your metabolism up and to keep your circulation and your lymph moving. Also really important for your brain health. That circulation is really important. There's so much research that shows that exercise can really decrease anxiety and depression, which we see in menopause. So on top of the other benefits that exercise provides us for, it can be helpful as a treatment with menopause. Mindfulness, so being aware that you are going through this change, extending yourself grace to go through this change. It can be really hard when you feel bad to get stuck in those emotions and stuck in those symptoms. But whenever we cultivate mindfulness, either through a spiritual practice or through meditation or through yoga, it helps us to become more aware of what's happening not only inside but outside of us. So then we can be more responsive versus reactive. This is helpful for all conditions across the board. Emotional support. So having your close group of girlfriends surround you, your family, your partner, this is really important to have that support because this is a vulnerable time for a lot of women. A lot of things that were normal for them now are not normal anymore. And some women feel like they're not themselves. They feel like they're in a body that's not theirs. So having that emotional support can be really helpful and supportive to just hold your hand as you go through it. And then bioidentical hormone replacement therapy, which is what that BHRT is very helpful. We can either restore function, which is what we typically do with herbs and micronutrients and diet. We want to restore or maintain what your body is doing, or we can replace it, which means we just give you the things that you're lacking. I personally like to do both. I like to encourage your body to keep doing what it knows how to do best. But I also know that sometimes we need to replace. Sometimes you're just not going to get that estrogen back. We're just too far gone. You're not going to get the testosterone back. You're not going to get the progesterone back. And depending on the person's history, their symptoms, their overall health, replacing it with hormone therapy can be really, really beneficial, protective for other things, and decreasing the symptoms and the experience of menopause as a whole. So that's what we're going to talk about next here. I want to differentiate between non-bioidentical hormones and bioidentical hormones because they're two very different things. Non-bioidentical hormones are hormones that are made in a lab and have a molecular structure that's different from the hormones that we make naturally, meaning it looks a little bit different to the body than our normal hormones. Premarin is a popular one, Provera or methyl testosterone. These are also some hormones that can be found in birth control. They have certain actions, like Premarin, it acts like estrogen, but the actual molecule and what that molecule looks like is different from what our body makes. So our body sometimes has different reactions or heightened reactions to these hormones because they're not in our natural state. We've also have research that shows that these hormones can be harmful, and particularly Premarin. Premarin is a type of estrogen that is taken from pregnant horses. We all know how big horses are and how big their babies are. You think about the type of estrogen a horse has to make to maintain a pregnancy. It doesn't make sense to give someone that type of estrogen. I think this estrogen is something like 20 times stronger than what our natural body makes. So this is why some women hear about hormones and they're like, oh, hormones cause cancer. Hormones don't by themselves cause cancer. Hormones imbalance can cause cancers, and hormones that stimulate our receptors excessively can cause cancer. And that's why I like to do bioidentical hormones versus non-bioidentical hormones. So bioidentical hormones are also made in a lab. They're not completely natural, but they're made in a way so that their molecules look like what our body naturally makes. So then when we give those to the woman, we don't have as many risks and adverse side effects because your body knows what to do with those molecules because it's made them before. Testosterone, estrogen, and progesterone are the ones that I most commonly replace in women. It's important that you stay on top of your hormones if you're going to be doing hormone replacement therapy. Labs are super important so that we can see what does your blood chemistry look like. We also look at your symptoms. Are symptoms better, worse? Are they completely resolved? That helps gives us information. And we look at past medical history. Does this person have a history of cancer in their family? If they do, what type of cancers? Did it affect the other women in their family? All of these things are important when we're thinking about moving into the bioidentical world. It's also important to note that we don't want to start hormones if we have been in menopause for more than 5 to 10 years. What's the rationale behind that? I get that question a lot. So as we go through menopause, we already know we're not making as much hormone as we once were. Eventually, the receptors for those hormones start to quiet down. They're not getting that stimulation from the hormones because we're not making it anymore. If your receptors have been on break for 5 years and then we give you hormones and all of a sudden they're stimulated, that can cause risks. That can cause proliferation or uncontrolled growth, which can then cause cancer. So again, this is a much longer conversation than what we have here with the webinar. It's really important that we get a full history for your hormones before you start, but overall bioidentical hormones are super beneficial. There's a lot of preventative and protective benefits that you get from it, and it's really great in decreasing symptoms. I'm just realizing that I didn't talk through what each hormone actually does. So I'll give you just a quick summary. We talked about estrogen, we talked about progesterone, but we didn't talk about testosterone. Testosterone is like your zest hormone. We typically think about this as a male hormone. And for the sake of simplicity, with men, we think about that libido. We think about that drive, that focus, that determination, the muscle mass. Whenever men want to lose weight, it's almost like they can blink and walk a mile and then like all of their weight falls off. Whereas women, we have to do all this dieting and exercising and the whole bit to get weight to fall off. It's mostly because men have more testosterone. If you have more testosterone, you're able to hold on to your muscle mass. If you're able to hold on to your muscle mass, you're burning more calories at rest, okay? So testosterone helps with that. Testosterone helps with that cognitive function. So being able to be sharp on your feet, remembering names, dates, places, making decisions, being able to focus. That's all testosterone, okay? Estrogen, we talked about its protective benefits for the bone, for the brain, for the breast, for the vaginal tissue. It keeps your vessels nice and healthy and elastic. That's why it's really protective for the heart and against clots and any cardiovascular accidents like strokes or heart attacks, because those vessels can expand and then contract as needed. Progesterone, which we talked about, this is really helpful for the cognitive function as far as mood and sleep. So they all have their different functions, which is why it's important to have labs and to also have a really comprehensive workup with your doctor so we can identify which one of these are off. And if they're all off, how do we maintain them or bring them back into a balance that's best for you? All right, so that's the end of the slide. That was a mouthful. Again, I do offer that free meet and greet. You can call here 480-588-6856 to see if we're a good match for each other. You can also schedule online if you would like. Now I want to open up the chat box for any questions that you guys may have. So if you have any questions, I really encourage for you to send them here so that I can answer some of them for you. Any questions? You guys seem really quiet today. All right. Well, it doesn't seem like we have any questions. Thank you. I hope you guys enjoyed the webinar. It was a lot of information. I've really enjoyed doing this series. This has motivated me to do more. What happens in a DEXA? So the DEXA is basically like a full body imaging. You go in and they take different images of your bones. So your hip bone, your femur bone, sometimes in the arm. And then they rate what that bone density looks like. So is the bone really dense, meaning that your bone's healthy? Is it starting to become less dense, meaning that we're losing bone? So it's literally just an imaging appointment that looks at different bones. You guys are so welcome. Any other questions? You're welcome. All right, friends. Well, we will be sending all of you guys emails with a replay function so that you can share it with your friends. You can replay it for notes. Also giving you more information on how you can reach me here at the office. I am open to any suggestions on any topics that you guys would like for me to present on. It's been a pleasure as always. Happy Friday, and I will see you guys soon.